Hello friends, in continuation to my talk on the subject of occurrence of repeat obstructive low urinary symptoms after a successful transurethral resection of prostate. In this video, I am talking to you of a section that if the patient has already developed a post TURP urethral stricture, how will you treat him and what are the important points that you should keep in your mind. If the patient has come to you very early following transurethral resection, his urethra has actually developed edema and reaction, and the fibrotic process is in the initial stage of fibroblastic reaction. So it is actually some kind of unstable edematous urethra, and if you do a sequential dilatation of this urethra over a guide wire under a intensifier and tell the patient to do clean self-dilatation at home, and some people like to use topical clobetasol in the urethra, you can have good results. But if the patient has come a little late and your clinical assessment is telling you that the disease process is actually more fibrotic, then you will have to consider doing oral mucosal graft urethroplasty for these patients. Now let me try and explain to you on the basis of different location of strictures that can happen following transurethral resection. Suppose the patient has meatal urethral stricture alone. So as I said, initially you can do dilatation over the guide wire and tell the patient to do self-dilatation subsequently. Say here is the case of meatal stricture, and you can do this dilatation over a guide wire using fascial dilators, or some people try and use a metal dilator under anesthesia, and thereafter we give our patients this small plastic dilator. This can be cleaned at home and they can apply clobetasol over this dilator and insert this into their meatus once a day or twice a day for some weeks, and this problem of meatal stricture can be easily solved. Those patients who have penile urethral stricture alone, and again if they have come at a very early stage, you can do dilatation over the guide wire and teach the patient self-dilatation regimen for some time. In one of our videos on YouTube, I have explained to you how to do the sequential fluoroscopic dilatation of penile urethral stricture, and you can see that for details. I want to share with you some results of this methodology of dilatation followed by self-dilatation by the patient and topical intraurethral clobetasol application. Here is a case of long penile urethral stricture, and then this was after few months of dilatation and self-dilatation, and this is the picture after 6 months. I'm sure you'll appreciate the gradual improvement in the condition of urethra. Here is a case of a stricture pre-dilatation, and here is a case of the same patient after 6 months of dilatation. So dilatation, if done in carefully selected patients where urethra is not very fibrotic, you can get reasonably good result. But if you have done dilatation a few times, or the patient has come in a late stage and you think it's a very fibrotic refractory penile urethral stricture, these patients will require oral mucosal graft urethroplasty in a long area, something like the one shown in this picture. There are some patients who will come with penile urethral stricture and also have residual prostate. These patients require dilatation, and not only that, the residual prostate should be resected for improvement. And after that, of course, patient will go on self-dilatation regimen. Now, here is a patient who has stricture as well as sufficient amount of residual prostate. He will require this kind of treatment. Then the patient may have stricture in the bulbar urethra. Again, some patients will have stricture with residual apical prostate or residual one lobe depending upon what the previous surgeon has done. So you have to combine DVIU along with apical resection and follow it with self-dilatation. But most patients have bulbar urethral stricture without residual prostate. So it's normal, nicely done PURP, but small stricture. These patients require cystoscopic dilatation or a DVIU. You can choose either of these two methods and then put the patient on self-dilatation regimen. Now I would like you to look at this urethra here. This is the normal urethral appearance. The stricture post URP can develop in distal bulb, and this is then called post URP distal bulbar urethral stricture. But some patients can develop proximal stricture, and this is called proximal bulbar urethral stricture. You should be able to define with the help of urethrograms whether it is a distal bulbar stricture or a proximal bulbar stricture. That differentiation is important. Here is a uretrogram of a patient who has a proximal short segment bulbar urethral stricture following TURP. Now these strictures should better be dilated, because if you cut them and they are close to sphincteric mechanism, you run the risk of injuring the sphincter mechanism. Now this is a patient of a post-URP urethral stricture, and as you advance the cystoscope here, you notice a small stricture which is easily dilatable, but most significant stricture is located in the bulbous urethra. Now these strictures can be dilated under vision. You pass a guide wire inside it, and over the guide wire you can gently exert some pressure and you can advance your cystoscope sheath easily inside, as done here. Now you will appreciate by looking at the prostatic fossa that there is healing going on. So it's a case of a very early stricture disease, and dilatation done once followed by self-dilatation should give you a reasonable outcome. If the patient has a refractory distal bulbar urethral stricture, then you will have to do oral mucosal graft urethroplasty, and here in distal bulb we recommend that you place a dorsal mucosal graft. If the patient has a proximal bulbar stricture and you want to do oral mucosal graft urethroplasty, such as here, you should put a ventral mucosal graft, because putting a dorsal graft in this location in proximal bulbar stricture becomes very tricky, and you go very close to sphincter mechanism. So you run the risk of creating post-URP incontinence. If you do a ventral bulbar graft, nothing happens, and you can close this nicely. So I hope you have understood some important points related to this disease. So thank you very much for your time.